Hi everyone, and welcome this afternoon to another Lymphoma Australia patient educational webinar on World CLL Day and also the beginning of Lymphoma Awareness Month. My name is Emma and I'm one of the nurses at Lymphoma Australia, and I'll be your host for this afternoon. In the spirit of reconciliation, Lymphoma Australia acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. I'll start with some quick housekeeping. If you do have any questions throughout the webinar, please put them into the Q&A function at the bottom of your screen. We will have a very small amount of time at the end to answer some of them. I do want to remind you that it's very difficult for doctors to answer very specific questions related to your personal situation without all of your medical information. So please bear that in mind when asking any questions today. I encourage you to ask those more specific individual questions to your treating haematologist. There is also a chat function, but this won't be monitored for questions. So please use the Q&A section if you do have a question throughout the webinar. If you miss any of the webinar today, please don't worry. It is being recorded and will be uploaded to YouTube and our Spotify channels within the next few days, and a link to the recording will also be emailed to you. We've had quite a few patient webinars this year, and today's webinar is a follow-up from the one we held in June on cytogenetics and molecular testing in CLL and SLL, which was presented by Dr. Sasanka Hundanetti, and you can find the recording to this session on our YouTube and Spotify channels. And for anyone who isn't aware, we do also hold regular online support groups via Zoom and some in person. We've just added multiple new group dates, both online and in person, until the end of this year. So you can find information on these groups on our events calendar on our website, and also register for them via our events calendar. And I'll put the link to our events calendar in the chat box as well. Now on to today's webinar, which is Treating CLL SLL, presented by Associate Professor Mary Ann Anderson. Dr. Anderson has been a practising clinical haematologist for the past 10 years, currently working both at the Royal Melbourne Hospital and the Peter MacCallum Cancer Centre in Melbourne. She's a foundation member of the CAR-T Consultant Group at Peter Mac, having joined the team at the inception of the unit in 2019. Dr. Anderson obtained her PhD from the University of Melbourne in 2017, where she undertook extensive clinical and laboratory studies of a novel approach to treating B-cell malignancies by harnessing apoptotic cell death with the agent now known as Venetoclax. Since completion of her PhD, Dr. Anderson has continued her studies into mechanisms by which B-cell malignancies evade targeted agents to develop therapeutic resistance. Welcome, Mary Ann, and thank you so much for being here today.
Thank you. It's a real pleasure to be here with you today. As many of you may know, the zanubrutinib has actually come onto the PBS today for the treatment of upfront CLL, which is a really wonderful advance, and venetoclax retreatment has become available as of today on the PBS. So it's a very exciting day in CLL, and it's great to be sharing that with you. So I recognise that this audience is quite diverse in its background and its knowledge, and genetically guided treatment of CLL is something that those of us who spend all day, every day thinking about CLL could talk to you about all day. So I've got a lot of slides today, and a lot of them are very complex. And I think my task today really is to try and distill some really very complex concepts so that you can understand what these genetic changes that your doctor might be talking about mean for you, particularly in the context of a world where increasingly we're moving away from chemotherapy and into novel agent approaches with venetoclax and other BCL2 inhibitors or BTK inhibitors. So just to give you a bit of a recap, this will be familiar to many of the people on the call. So CLL is a disorder of lymphocytes. So you see accumulation of these small mature lymphocytes, often in the blood. On the blood film, you can see smear cells, and the cells are characterized by aberrant expression of a T cell marker, CD5, as well as CD19, a typical B cell marker. Patients will typically be diagnosed with CLL as their lymphocyte count progresses beyond 5 monoclonal B cells in the peripheral blood. And there is a precedent diagnosis of monoclonal B cell lymphocytosis where the abnormal cells are seen, but they do not reach this threshold of 5. And one of the things that often confuses patients is this distinction between SLL and CLL. So SLL and CLL are the same disease, but in different body compartments. CLL is classically seen in the peripheral blood, so we see those high lymphocyte counts, whereas SLL is classically seen as large lymph nodes and collections of lymphocytes in nodal tissue. So same disease in different spots of the body. And as time progresses, CLL can also be characterized by large lymph nodes. So you can see here is a blood film. So patient's blood's been taken out of their arm, smeared onto a glass plate and looked down under the microscope. And you can see the red cells, which we expect to see, and you can see that there are a large number of these purple cells, and they are the lymphocytes. And these cells here that look like smudges are the smudge cells, which are very classic of CLL. And this is a patient here whose bone marrow has a significant amount of CLL in it. And indeed, you can see that it's almost all replaced by these small lymphocytes. And this is an unfortunate individual with very significant lymphadenopathy or lymph nodes under the arms. So CLL is a disease of the elderly. Although we do certainly have patients diagnosed in their 20s and 30s, the median age of diagnosis of CLL is around 65 years. And in Western populations, it is the most common type of leukemia affecting adults. Rarely, we also recognise clusters of families who are affected by this condition. So that's the background to CLL, which is probably very familiar to most people. And I'd like to now dive straight into talking about the impact of genetic testing and genetic findings on treatment with Venetoclax. So Venetoclax is a small molecule inhibitor of BCL2. So it's a tablet that's taken every day, and it inhibits this protein called BCL2. In CLL, BCL2 is overexpressed, and this means that the cells cannot undergo programmed cell death or apoptosis. So by adding Venetoclax into the system, this binds to BCL2, inhibits it, and allows the CLL to die. Venetoclax is a very effective treatment for CLL. This was the phase 1 first-in-human study that we conducted here at Peter Mac and Royal Melbourne. And that showed in patients in an era where we only had access to chemotherapy that 79% of patients who really had exhausted all other treatment options responded to this agent. So it was a transformational change in the way that we treat CLL and think about CLL. But one of the things that really excited us as we were doing this trial was that patients with 17p deletion and p53 dysfunction were also responding very well to the drug. The overall response rate was 71% amongst those patients with adverse genetic features. And you know, we know very clearly from chemotherapy studies over many years that loss of p53, which is the main tumour suppressor gene in humans, and that can be detected by mutations in p53 or by deletion of chromosome 17p. That leads to very significantly inferior outcomes when treated with chemotherapy. And so this paper was published back in 2016. And for the first time, we were seeing that the overall response rate amongst all comers was very similar to the overall response rate that we were seeing amongst patients with P53 dysfunction. So that was an enormously exciting first discovery. So subsequently, Venetoclax was examined in combination with rituximab, and this is the Murano study that compared Venetoclax rituximab to bendamustine rituximab. And you don't need to be a statistician to see that patients are enjoying significantly longer progression-free survival and overall survival when treated with Venetoclax and rituximab compared to bendamustine rituximab. So this really established Venetoclax as superior to chemotherapy in relapsed refractory CLL for all patients. What we saw, though, is that we were starting to be able to understand which patients do very well with treatment and which patients do less well. And one of the key factors that determine the duration of a response to this therapy is elimination of all detectable CLL. So we measure small amounts of CLL using this study called minimal residual disease. And that can be done with a couple of different techniques, either flow cytometry or clonoSEQ, which is a genetic test. And what we have subsequently learned from this Murano study and other studies is that with Venetoclax treatment, if you eliminate your MRD or your minimal residual disease, your outcomes are likely to be much better than if you fail to eliminate your minimal residual disease. And so we asked the question, how do we work out which patients are likely to eliminate their minimal residual disease? The first thing to note is that patients treated with chemotherapy across the board struggle much more to eliminate their minimal residual disease compared to patients treated with Venetoclax. But then if we look at the impact of genetics on elimination of minimal residual disease, the only significant finding is that P53 dysfunction actually portends a lower likelihood of MRD elimination. And so what we're seeing is that patients are responding initially to treatment with Venetoclax. So this is looking at patients with and without P53 dysfunction, and we can see that their lymphocyte count, their lymph nodes, their bone marrow CLL infiltration is all the same, irrespective of their P53 dysfunction. But over the longer term, patients with P53 dysfunction are not doing as well as patients who are P53 intact. And we believe that that is because it is harder to eliminate the minimal residual disease when patients harbour P53 dysfunction. The other thing that we observed when we were treating patients with Venetoclax is that we see over time with continuous treatment that there are mutations in BCL2 that arise in the blood. And these mutations arise in the blood as the patients develop progressive disease. And these mutations actually confer make it more difficult for the Venetoclax to bind to the BCL2 and make it more difficult for Venetoclax to do its job. So at least part of the reason why patients start to progress on Venetoclax is the development of these mutations in BCL2 that make the CLL less sensitive to Venetoclax killing. And interestingly, these mutations are never reported prior to treatment with Venetoclax. They arise in the setting of Venetoclax treatment. And we described the first of these BCL2 mutations, but indeed there are a large number of BCL2 mutations that have subsequently been described. And now that Venetoclax retreatment is becoming a reality on the pharmaceutical benefits scheme, understanding whether there are BCL2 mutations present might help to predict whether Venetoclax retreatment is a good thing or not for patients. So this is just a laboratory experiment that we conducted. And the lower this number, the lower the dots, the more sensitive the patients are to treatment with Venetoclax. And these are the patient cells prior to commencing Venetoclax. At the time that they develop progressive disease on Venetoclax, you can see that the cells are much less sensitive to Venetoclax. However, the majority of those cells would still respond to Venetoclax. They're just less sensitive. So what we know is that there's something going on in the patient's body, in the microenvironment where the CLL cells sit, that is conferring an additional layer of protection above and beyond the BCL2 mutations when patients develop progressive disease. So that's the relapsed and refractory setting. What about patients who are receiving Venetoclax in the upfront setting for treatment of their CLL? So this is the CLL 14 study, and it compared Venetoclax and obinutuzumab to chlorambucil and obinutuzumab. And what we're seeing with this therapy is that there is a significantly improved progression-free survival favouring the Venetoclax arm, but that's not translating into an overall survival benefit yet. And that's almost certainly because these are patients with upfront CLL, and those patients do very well for many years typically. What we saw in the CLL 14 study is that Venetoclax and obinutuzumab is superior to chlorambucil and obinutuzumab. But what we see when we look at the progression-free survival, so the duration of response that patients enjoy from this treatment, the patients who have unmutated disease are the patients who benefit the most. So you can see that patients in this curve here who have unmutated disease and are treated with chlorambucil-based therapy, these are the patients who do very, very badly. If we give these same patients Venetoclax and obinutuzumab, they have a very significant improvement in their outcome. There is an improvement in outcome for the patients with mutated disease as well, but it is those high-risk genetic patients who stand to benefit the most from the novel agent therapy. Again, it's a similar story when we look at deletion 17p. The patients who do worse are those patients who are treated with chemotherapy and have deletion 17p disease. And we can significantly improve that outcome in both groups of patients, but particularly in those patients with 17p deletion if we treat them with Venetoclax instead. One of the things that the CLL 14 study did was it looked at the development of new mutations amongst patients treated with chemotherapy compared to patients treated with Venetoclax. And what we saw is that amongst the Venetoclax treated group, the percentage of cells that harbour 17p deletion actually went down in 2 patients. There were no patients where 17p deletion decreased in the chlorambucil treated group. Similarly, amongst the Venetoclax treated group, there were no patients with increasing proportions of del17p, but 3 patients in the chlorambucil group showed increasing proportions of del17p. So compared to chemotherapy, Venetoclax appears to have a favourable effect on the clonal evolution of the CLL. Again, if we look at TP53 mutation, which again confers the same problem that you see with deletion 17p, you see that the patients with mutated p53 do vastly better when treated with Venetoclax compared to chemotherapy. And we also see that the percentage of cells in which there is mutation in p53 actually goes down in most patients with Venetoclax treatment, whereas there are certainly some patients where it increases in the chlorambucil group. Again, the story is very similar with 11q deletion, which is another adverse prognostic marker. All patients do better with Venetoclax, but it's the patients who have deletion 11q who stand to benefit the most from Venetoclax compared to chlorambucil. Again, we see more cases of rising 11q fraction in the chlorambucil treated group compared to the Venetoclax treated group. Again, BRCA3 mutations, which are another commonly mutated gene in CLL, these patients do best when treated with Venetoclax. and the proportion of BRCA3 mutations rising with therapy is higher in the chlorambucil compared to the venetoclax treated group. Oops. This is a similar story with Notch1 and SF3B mutations, which are other mutations that have been described in CLL. And Notch1 is significant because of its association with Richter's transformation. So the other really key genetic test that many of us look for is complex karyotype. So complex karyotype refers to patients who have more than three karyotypic abnormalities seen on a standard karyotype. And patients who have more than 5 of these abnormalities are referred to as highly complex. No surprises that patients in whom there is a complex karyotype or a highly complex karyotype do worse than patients with a normal karyotype when treated with Venetoclax therapy. But again, what we see is that when we look at Venetoclax versus chlorambucil, that difference in outcome based on the complexity of the karyotype is significantly ameliorated. So the curves are pushed together compared to what you see with chlorambucil-based therapy. And again, one of the things that we often look at is not just one genetic abnormality in isolation, but the combination of genetic abnormalities. And you can imagine that a complex karyotype and TP53 dysfunction really is the double whammy in terms of adverse prognostic effects. And that is borne out in these progression-free survival curves amongst the patients treated with chlorambucil in the CLL14 study. If we look at the same patients treated with Venetoclax, however, what we see is that the curves, again, are much closer together. So that very adverse prognosis conferred by complex karyotype P53 dysfunction is significantly ameliorated by treating the patients with Venetoclax rather than chlorambucil. And again, while I showed you the overall survival curves of all the patients on CLL14, which were not significant, when we look at overall survival based on your mutational profile, what we see is that these patients with no deletion 17p are doing better than the patients with deletion 17p. But patients who have deletion 17p and are treated with Venetoclax rather than chlorambucil, those patients have a better overall survival than the chlorambucil group. The overall survival amongst patients based on their IGHV mutation is still less clear, and it really those curves are yet to show significant divergence. So if we look at the multivariate analysis of the CLL14 study, it can help us to pull out factors that portend significantly improved or worsened progression-free survival or overall survival. So we know that progression-free survival is better if you're treated with Venetoclax. Having a complex karyotype or a deletion 17p, or indeed having a high-risk category for tumor lysis syndrome, all of these factors continue to confer worse outcome in the long run when treated with therapy on the CLL14 study. However, other than del 17p, none of these factors actually reached significance in terms of overall survival. So deletion 17p remains a key prognostic indicator even when treated with Venetoclax, but the outcomes in these patients are significantly better when treated with Venetoclax compared to when treated with chemo. So again, this is a summary of the mutations that were seen amongst patients treated with Venetoclax in yellow and patients treated with chlorambucil in blue. And what we see is that over time, there are many more mutations arising in the chlorambucil treated group than compared to the venetoclax treated group. Now, this data may change over time because patients treated with venetoclax did so much better, there was less progressions and so less opportunity to observe clonal evolution with progression. However, this preliminary data would suggest that chemotherapy is driving more clonal evolution in CLL compared to venetoclax. So it may be that in time, part of the reason why patients are doing better with venetoclax is because they have less drive for new clonal changes to occur compared to patients treated with chlorambucil. And you may recall that I spoke about these on-target BCL2 mutations that were seen in patients treated in the relapsed refractory setting with continuous venetoclax. What I'd like to demonstrate with this slide is that none of these mutations, these on-target mutations, were observed in the upfront setting on the CLL14 study. So perhaps treating patients earlier with venetoclax to these very deep responses may mitigate some of those on-target mutations that we see in the relapsed refractory setting with continuous treatment. And I just wanted to show you what I think is a very nice diagram that demonstrates clonal evolution in action. So this is a single individual. So this is a patient who has who does not have CLL early on. So they've got some B cell damage, and they've got these kind of damaged but non-malignant cells. Then they go on to develop this MBL that we spoke about in the beginning. You've got the CLL phenotype, but you don't reach the threshold for more than 5 × 10⁹ lymphocytes in your peripheral blood, and you don't technically have a diagnosis of CLL. So you can see there are more, when they progress from some damage to MBL, you see these abnormal cells and you start to see the CLL phenotype. And in amongst these CLL cells, you also see cells that harbour P53 in red. The patient then goes on to develop non-symptomatic CLL, and they've got at least 4 clones of abnormal cells: the damaged cells, the CLL cells, the P53 dysfunctional cells, and another mutation. They then have further progression of their disease, and they have symptomatic CLL. So their doctor gives them some treatment. They then they respond, and then they relapse. If the patient is treated with chemotherapy, the cells that grow out are enriched for P53, ATM, SF3B1 mutations, so very genetically aberrant and difficult to treat. If the patient's treated with venetoclax, for instance, the cells that grow out are more likely to be have on-target mutations in BCL2, etc. So this is a sort of a longitudinal view of how the genetic profile of an individual CLL changes over time and how that is influenced by the treatment that they receive. So I'd like to, with that, move on to BTK inhibitors, because the story is just as complex with the BTK inhibitors. So this is the BTK pathway. Basically, it is the pathway of signaling that goes from the B cell receptor on a cell surface through to the nucleus. And BTK inhibitors, or Burton tyrosine kinase inhibitors, act on the BTK protein. And they are inhibited by drugs like ibrutinib, zanubrutinib, and acalabrutinib. There's another class of drugs that act on the PI3 kinase, which is part of this pathway, and that's highlighted by idelalisib, which is not used as frequently these days, and we can talk about that in another session if you'd like. So ibrutinib monotherapy in relapsed refractory CLL. This was one of the early papers published in the New England Journal of Medicine in 2013. And again, these were all patients who had no options except chemoimmunotherapy and had been multiply pre-treated with chemoimmunotherapy. So the kinds of patients that we would consider to be at very high risk, and that thankfully we see much less of these days. What we can see is that the progression-free survival of these patients was excellent, and that this was affected by recognized adverse mutations. So 11q deletion and 17p deletion patients did worse. Similarly, patients with IGHV unmutated status did worse. The Alliance study looked at ibrutinib and rituximab, or ibrutinib alone versus bendamustine rituximab. What we saw with this study was that the ibrutinib rituximab group did very similarly to the ibrutinib group, and that's why those of you who are treated with BTK inhibitors will typically be treated with single agent BTK inhibitors rather than the BTK inhibitor combined with a monoclonal antibody. But again, we're seeing a common theme that the novel agent therapy is superior to the chemoimmunotherapy. What about patients who have p53 dysfunction? What about their response to ibrutinib? So what we see is that for patients with p53 dysfunction who are treatment naive, they actually have an excellent progression-free and overall survival. In the relapsed refractory setting, however, patients with p53 dysfunction are not doing as well. And if we look at a large number of ibrutinib-based studies, what we start to see is that while p53 dysfunction is clearly an adverse prognostic marker amongst patients treated with ibrutinib for relapsed refractory disease, it is not clear that p53 confers adverse prognosis when ibrutinib is used as an upfront therapy. So the 4-year PFS rate in TP53 dysfunctional patients was 79%, which is really very similar to the PFS that we'd expect for all comers. And there are some authors and some experts in the field who would argue that ibrutinib is still the only agent when used in the upfront setting that does not demonstrate adverse outcomes among patients with p53 dysfunction. And some people would argue that this is a reason to use a BTK inhibitor for p53 dysfunctional disease in the frontline setting. That argument has both pros and cons, and happy to have it with any of you who'd like to discuss it at length later. Other people would argue that venetoclax based therapy will provide very deep responses, and therefore those responses are likely to allow for time-limited therapy, and that those deep responses are more likely in the upfront setting. So it's very controversial what this data mean in terms of upfront treatment decisions, and different clinicians will interpret it differently. And I don't think we have a clear answer at this point. So what about ibrutinib rituximab compared to FCR, which is a standard chemoimmunotherapy group? So if you look at all comers, the ibrutinib rituximab patients do better. But what I'd like to show you is that with FCR, if you're IGHV mutated, your results are almost the same as if you're treated with ibrutinib. So FCR is not inferior to ibrutinib-based therapy, provided you have good genetics. Whereas it is very clear that in patients who are IGHV unmutated, that FCR is an inferior treatment. So we touched on clonal evolution with venetoclax, and sadly, there is a similar theme seen with ibrutinib and BTK inhibitors. So one of the first mutations reported with ibrutinib treatment was this CYS481S mutation. And what CYS481S does is it means that CLL cells become significantly less sensitive to ibrutinib therapy. And in a very similar story to the venetoclax story, this mutation was first described, and then a whole other gamut of mutations, both in BTK and in the downstream PLCY2 gamma protein, were subsequently described. So if we think about ibrutinib, ibrutinib is what we call a covalent or irreversible BTK inhibitor. And this was the first generation of BTK inhibitors. There's a second generation of these covalent BTK inhibitors that includes acalabrutinib and zanubrutinib. All of these agents bind to the C481 residue of BTK, thereby blocking the ATP binding pocket and preventing catalytic activity. And this underpins why mutations in this particular protein lead to ibrutinib resistance. And unfortunately, mutations in C482Y will result in patients being resistant not only to ibrutinib, but also to acalabrutinib and zanubrutinib, because they all bind to that protein. So, we really did, it was, as much as we learn and we get new drugs, we also learn that there are limitations to these drugs. So what about acalabrutinib and zanubrutinib? So this is called a kinome, and the red dots are where ibrutinib is binding. What I'd like to draw your attention to is that compared to ibrutinib, acalabrutinib dots are much smaller and fewer. And what that means is that acalabrutinib binds to less kinases compared to ibrutinib. This has advantages and disadvantages. The advantage is that acalabrutinib is seen, at least, and perceived to be a cleaner BTK inhibitor with potentially less side effects. However, because acalabrutinib is binding to fewer kinases, it is more susceptible to mutations in those kinases conferring resistance. Whereas because ibrutinib binds to more of the kinome, a mutation in one part of the kinome does not necessarily lend itself to absolute resistance to ibrutinib. So potentially you could say that the first generation of covalent BTK inhibitors are more proofed against point mutations leading to resistance compared to the second generation. That comes at the cost, of course, of potentially more side effects because it's a dirtier drug in terms of the kinome. Nonetheless, unsurprisingly, we do have a number of mutations that have been described conferring acalabrutinib resistance. Zanubrutinib is analogous to acalabrutinib, so compared to ibrutinib, it binds to less sites in the kinome. And this is the Alpine study that compared. Sorry, did you guys, I think I might have been muted.
Yeah, it was just muted for a minute. So I think
okay.
You said the Alpine study and then...
Okay, yeah. Sorry. All right. So zanubrutinib is in no way inferior in terms of progression-free survival compared to ibrutinib. But unfortunately, we see again with zanubrutinib that when patients develop progression, they usually progress with these on-target BTK mutations. So what we really needed was a BTK inhibitor that could get around that on-target resistance mutation conferred by C481 mutations, which confer resistance across the board to the covalent BTK inhibitors. And that's really led to this new generation of non-covalent BTK inhibitors, including pirtobrutinib or Loxo, which some of you may have heard about. And these agents are not affected by C481 mutations. So treating patients with pirtobrutinib who have ibrutinib or acalabrutinib resistant disease is likely to be efficacious. And indeed, we know that 71% of patients with a known BTK481 mutation will respond to pirtobrutinib, which is just remarkable. And this was the Broome study, which looked at pirtobrutinib treatment in patients with a variety of B-cell malignancies. And you can see that the progression-free survival, the overall response rates were excellent, and the progression-free survival was excellent on the study. So again, just to look at a patient journey from a mutational perspective, if we look at the lymphocyte counts of this patient, so they're pretty low and then they start to rise on zanubrutinib. The patient, as that happened, the patient developed a C141 mutation. So the patient developed a zanubrutinib-related mutation, which meant that their disease progressed. They were then treated on pirtobrutinib, and you can see that their white cell count went down. Alongside that, the zanubrutinib mutation went down, but as their disease began to progress on pirtobrutinib with an elevation in their lymphocyte count, we see a pirtobrutinib-associated mutation arising. So pirtobrutinib solves some of the problems that we see from mutations conferring resistance to the BTK inhibitors, but it is not. It's not the end of the story, because we start to see mutations arising that are specific to pirtobrutinib. And again, a whole number of pirtobrutinib-related mutations have been described. So this is another way of showing the clonal evolution of a patient. And so this is before treatment, and you can see that this patient has a variety of different mutations even before treatment starts. They get treatment and none of the mutations are detectable. They then start to relapse on treatment, and you can see that they relapse with these PLC-Y gamma mutations, with BTK mutations, and the BTK mutations, which are the on-target mutations, are absolutely new compared to before treatment. So they're relapsing with clonal evolution that is adapted to the drug that they're on. And again, this is another patient, variety of mutations prior to treatment, no mutations detected while they're doing well, but as they relapse, we're starting to see on-target BTK mutations arising. Another way of looking at this is to look at a patient who gets treatment, and as the disease grows out, it grows out with on-target mutations to the disease, to the particular agent that they're receiving at the time. And a large variety of BTK mutations have been described in all of the agents that are in common use, so ibrutinib, acalabrutinib, zanubrutinib, pirtobrutinib. And understanding these mutations can help us to tailor drug selection, right drug for the right patient. So I'd like to leave it there, because I really would like to leave some time for question and answer. So I'm going to stop talking and open it up to the floor.
Thank you so much, Marianne. It's such a complicated concept, but so interesting at the same time. And I guess it really demonstrates to me that even though we have these new targeted therapies, there's definitely no perfect therapy, and we're continuing to learn more and more and tailor specifically to individuals as well.
100%. And I think that we don't, we're really only at the beginning of this journey. So I think we're moving towards a world where we can really individualize treatment to a specific patient's mutational profile. I don't think we're quite there yet, ready for prime time yet, but you can see that understanding what mutations are present in an individual can start to help us to make more nuanced decisions about what treatments we'd like to give them.
Yeah. We've got a couple of questions in the Q&A section, but I just want to ask one first myself.
Yeah.
So you described the BTK inhibitors and Venetoclax as monotherapies. Are there combinations of these two therapies, in clinical trial or on the horizon? And what kind of, I guess, results are we seeing from those combinations?
Yeah, so the original studies in Venetoclax were done as monotherapy on continuous treatment. That's not the way we use Venetoclax now. So both the Murano and the CLL14 studies were combination studies. In Murano, which is for relapsed refractory CLL, Venetoclax was used for 2 years as time-limited therapy in combination with rituximab. In CLL14, which is the treatment-naive study, the Venetoclax was used for 12 months in combination with obinutuzumab. And what we see is that using time-limited therapy, we see far less of those on-target mutations. So if you think about the genetic drivers, if you continually subject someone to, if you continually subject the cells to pressure from BCL2 inhibition, they will start to evade that with these mutations. We see far less BCL2 mutations arising when we use time-limited therapy. So a short, sharp treatment and then remove the clonal driver, and you don't start to see these mutations coming out. And so this underpins this whole concept of Venetoclax retreatment, right? So you can imagine a patient who gets 2 years of Venetoclax rituximab. They might, have a very low level of BCL2 mutation, but it's not enough to show progressive disease. Their disease is well controlled. They enjoy 3 or 4 years without needing treatment. Their disease relapses. Because they haven't got the clonal driver, the clonal pressure of the Venetoclax, it's likely to relapse with a whole suite of different mutations, of which we hope BCL2 mutations are quite minor. And then coming back in with Venetoclax should help the disease again. But if they were relapsing with a significant proportion of a BCL2 mutation, you might think twice about giving them Venetoclax again. And of course, there's a whole heap of new BCL2 inhibitors that are coming down the track, some of which allegedly actually avoid some of these known mutations.
That's going to be my next. Oh, sorry.
Oh, and then
I was just going to say,
briefly, that was one of the points I was trying to get at. So the BTK inhibitors we use as continuous therapy, and we use them as continuous therapy because we don't see those very deep responses. So we know that if we withdraw the drug, the disease is likely to come back quite quickly. So we need to give them continuously. But we also give them as monotherapy because there's no good evidence that adding in a monoclonal antibody improves outcome. And so that's why the paradigms of treatment are slightly different. And that has implications for mutations and resistance.
Yeah. And we've seen newer generations of the BTK inhibitors. Are there newer generations of Venetoclax coming?
Yes. So there 100% there are. So there are studies ongoing at the moment in our centre, included with Venetoclax or BGB 11417. And internationally, there are a number of BCL2 inhibitors that are being tested actively in clinical trials, many of which look very promising.
All right, so we've got a couple of questions in the chat box. Thank you for answering mine first. We've got one question from Alicia. It says, on the studies, is the MRD based on peripheral blood or bone marrow?
Yeah, so most studies will look at peripheral blood. And the reason is that the bone marrow MRD testing is very similar to peripheral blood. You might detect, you probably improve your accuracy by 2 or 3% doing a bone marrow as compared to peripheral blood. But for 2 or 3%, most people don't want to have a bone marrow. So most of us would use, and most studies are designed using peripheral blood MRD rather than bone marrow MRD.
Thank you. And our next question is, the mutations discovered on relapse, what tests are done to find these mutations?
Yeah, so typically somebody who is relapsing, we would do a bone marrow biopsy. You don't have to, you can do it on peripheral blood, but we would typically do a bone marrow biopsy because their disease is progressing, we're looking at a different type of treatment, we want to have a baseline. And so if I'm doing a bone marrow, I would probably do it on bone marrow, but you can do it on peripheral blood. And the tests that I would typically order are cytogenetics, so looking for clonal evolution, looking for complex karyotype, because that is a feature of disease that is relapsing. But more importantly, next generation sequencing, which will show you your P53 mutations, your Notch1 mutations, etc., etc. Now, many sites don't offer BCL2 or BTK testing as a routine. So you'll have to ask your individual doctors if that can be done at your site. It is available in Australia, but it's not a test that's really ready for NADA sort of accreditation and routine. It's not ready for prime time yet, and so it's done in a semi-experimental manner at centres that do a lot of CLL.
Yeah, so is it mostly kind of more so done in a trial setting rather than
so
as a
clinical
standard
trials
test?
will often do it because it's an
Yeah.
active area of research. We do have capacity to do it for our patients. The thing is, the reason that it's not prime time yet is that we don't have prospective clinical data that we should make clinical decisions based on it. Now, as a scientist and a clinician, I must say that it is something that I would consider and it's something that I take into account. But I don't have a cohort of 1,000 patients where they've done mutationally guided treatment decisions. So it's sort of hard to say you should do it. What I can say is that I think it is likely to become a more common feature of routine practice as the years go by. And perhaps 5 or 10 years from now, it will be done routinely and decisions will be made on it. At the moment, it's a little bit hard to recommend that because it's still in such early days of its evolution and the clinical data is yet to catch up. So it's something that I take note of, that I certainly take into consideration, but it's not necessarily something that is done as a routine thing and can be done everywhere.
Thank you. Well, I don't think we have any other questions at this stage. So we can probably finish up a little bit early the webinar, unless anyone else has any questions, be quick and type them now. But I'd like to say thank you so much again, Marianne, for joining us today on World CLL Day and start of Lymphoma Awareness Month. And as you mentioned, we've got one question come in. We've had some great news come through, just saying thank you for a very informative talk.
Oh, thank you.
Some great news coming through today with zanubrutinib. So it seems like the perfect day to have a webinar on CLL. If anyone does have any further questions, please feel free to call our lymphoma nurse line on 1-800-953-081, or you can also email us and we can forward your questions to Marianne if you have any as well, or we can answer them ourselves as well. So thank you so much, everyone who's joined us live. This has been recorded and will be uploaded to YouTube, so you can watch it over again as well. I know I definitely will be watching it to really absorb all of those concepts. But thank you so much for joining us and enjoy the rest of your day.
Thanks, everyone. Bye-bye. Have a good day.
Thank you.